share it. Sorry, I'll have to repeat that again. So good morning and welcome again. So this is a webinar on introduction to Veneers. This is a webinar that I will take you through a quick, what do you call, a gist of everything regarding Veneers, right from smile designing up to bonding. Again, it's just 1.5 hours. I will be taking any questions in the end. So you can always keep typing your questions in the chat box. I might not be able to take all the questions I know, but as much as I can, I would be finishing the questions that will be asked today. All right. No, you cannot record it on your computer, Dr. Jyoti. Uh, I will be recording it and I will be sharing it on YouTube. So that's how it is going to be. All right. Perfect. So let's begin today's lecture without wasting any time. And then we see how it goes. Some of you might have attended part of this or a portion of this before, but yeah, this is a much more comprehensive summary of veneers as such. So you understand what exactly is important when it comes to a case wherein you are planning to do indirect veneers. So the topic for today, of course, we will understand smile designing a little bit. We'll understand the foundation of lasting veneers and what all is important when it comes to treating a case with veneers. Now, whenever we treat an aesthetic case, we need to understand there are a lot of factors involved, and we know that for a fact. It's not just cutting teeth and sticking ceramic on it. A lot of things are generally taught when we are studying. A lot of things we learn from our experience, and a lot of things are generally learned later in life. Now, the thing that we will focus on today a little bit more is one, consent, which I feel is super important when it comes to doing any case that is completely elective. Second thing is ethics, so which is super close to my heart. I would generally not do any harm to the patient. So make sure that it's an irreversible treatment, whether you are doing composite veneers, whether you are doing ceramic veneers, whether you're doing prep veneers, non-prep veneers, it's generally an irreversible treatment. Something or the other would be damaged if you try to remove your non-prep veneers also. So it is not a quick fix to lot of problems. So we choose our cases wisely. If there are alternatives, we provide that to the patient first, even though if it means that we lose that patient. Patients' expectations, we know that they are increasing humongously. So we need to understand that we will be able to match the patient's expectations. And if you feel that the expectations are not realistic, we will pull ourselves back from attempting that case. And finally, the treatment plan, which is, of course, again, very important. You should know what exactly you are doing on day one, and you should ideally stick to that treatment plan, what you provide to the patient. Of course, things can change during the way, but shouldn't ideally be changing. So just a quick introduction about myself. So I'm Dr. Ritul Agarwal. I have been practicing in Dubai for over 13 years. I am a specialist prosthodontist and an implantologist. I also do some Botox for TMJ mainly. And I am also an examiner for the Royal College of Surgeons, Edinburgh. This is my Instagram. So if you don't follow me, you can do follow me over here. If you have any questions after the lecture, you can always just drop me a text on this. I'll be more than happy to answer in case I'm not able to finish the questions today. I would request everybody to just turn their videos off right now so that the slides don't get hidden. Just give me 1 second. I'm just doing that. Awesome. Cool. So that's my association with the Royal College of Surgeons, and I'm an examiner for the membership in prosthodontics examination. And yes, if any prosthodontist would be appearing for that exam, you might find me on the other side of the desk. So these are three cases of mine, and which we need to understand is something called as personalized smile design. Now, personalized smile design is what means is basically that a smile is not a copy paste. We choose our patients, we decide our treatment plan. Some patients might have protruded teeth, some patients might have retruded teeth, some patients might have a gummy smile. So on and so forth. So everything has to be personalized. What is persona? Persona is basically we design the smile based on the person's personality. So, and that too, what personality the person would like to project when the person is outside in the world among the people that the person is mostly in. So, if I would want myself to be projected as a leader, my smile design would be accordingly for myself. Suppose some person wants to project themselves as a delicate person, so the smile design would be based on that, and that's what we are going to discuss today. We need to understand also that the demand for facial aesthetics is increasing day by day for many reasons. One, everybody wants to look good. Second, because of the social media, everybody is more present in the world. People are taking more pictures of themselves. They are more free to put it outside in the world, and everybody wants to look better than what they look today. So you are getting more and more patients as a dentist for getting their teeth fixed. But as a dentist, it's our duty, of course, first always to do no harm. So if you feel the patient can benefit from an alternative treatment, please make sure that you provide that to the patient. Don't just cut the teeth and stick some ceramic on it. Because cutting teeth also is an art. You can cut your teeth very small and the ceramic guy would do the job in a better way. It would look good on Instagram before after, but what is inside nobody shows you. So if you look at a lot of Instagram pages of dentists who generally show their before afters would be scared to show you their preps. You are only going to see before and afters. So doing a minimal prep, doing an excellent veneer is the art. Cutting the teeth and putting a ceramic on it is not the art. So that's the thing that we will have to focus on. We have discussed that every smile is different. So a patient comes to me, the plan is different. It is never the same plan. I would not do 20 veneers for everybody. I choose my number of veneers. I decide for the patient what would be the ideal plan for it. And that would be the case. So a scenario like this, wherein I could have done 20 veneers, I could have done veneers on the lowers as well. What we ended up with is doing some composites on the lower, doing some whitening on the lowers, and managing the upper teeth with some veneers and crowns. So as a dentist, I generally do not do lower veneers because one, they are not very aesthetically important teeth. And secondly, I prefer doing only the uppers, and most of the time I'm able to manage my cases with the upper veneers alone and with sub treatment for the lowers. A scenario like this wherein you have four teeth that are absolutely eroded because of some habits, again all the other teeth were pretty okay. What I decided to do for this patient was just some whitening, again remove the attachments on the upper teeth, do some four veneers for that patient, and we were able to manage the case with minimal number of teeth involved. I could have managed it with two teeth as well, but I mean, in terms, I would have, I mean, chosen to do four for her because I mean of the aesthetics that were important for this patient. Once again, I would request, yes, turn your videos off, please, so that I mean the side of the screen is not blocked. So just keep turning your videos off. Perfect. Thank you. So whenever we look at a case wherein we see an aesthetic case or any case in terms of restorations, there are three things that are important. One, we will focus today on smile analysis. We are going to also focus on soft tissue. We are also going to focus on personality and tooth shape. The first thing that I will focus on is how do we decide what tooth shape will suit what patient. Not every tooth shape would be suitable for everybody. So we decide as a dentist what to shape we want, not the technician. So the technician is not telling you that this is the shape that will suit the patient. You as a dentist, you as the artist, you as the person designing the smile should be aware of what kind of smile would perfectly choose that patient. All right. Just give me 1 second quickly. Sorry for that. I don't know why this is happening. Um, and even this we will stop. Perfect. Sorry for that. So now Carl Jung was a professor. He kind of did a lot of research and he came to a conclusion that there are some symbols that are uniform when it comes to human nature. He called them archetypes, and the archetypes are as follows. Anything that is vertical, it signifies strength. So the big cities in the world want to build tall skyscrapers just to show strength. Anything that is horizontal, it signifies stability. So every time you go to a beach, you go to a mountain, you see anything that is flat, it signifies more of a stability. Anything that is inclined, it signifies dynamism, and anything that is rounded, it would signify delicate. So we now have four things. We have the strong, the calm, the dynamic, and the delicate. And these are the four T shape that we have studied when we were in our universities. So you have the rectangular two shape, you have the square two shape, you have the triangular two shape, and you have the delicate two shape. In general, in nature, you have all the four two shapes that are generally available. So you have the rectangular two shape, you have the oval two shape, and as I discussed, the square and the triangular. But when we do our smile designings, we generally avoid the square and the dynamic, I mean the triangular ones. The square is generally not very an aesthetic proportion, whereas the triangular ones, you will most of the time end up with a black triangle. So of course, we tend to avoid these two shapes. I like to play with my rectangular and my oval two shapes so that we get a two shape that is suitable to the person's personality. So that's how we decide on the personality. If the person is wanting to project as a very strong person, I will go with more rectangular teeth. A person I would want to project as a more neutral person or would not have any of such, then I will add some ovalness to the tooth. Whereas if a person wants to project as a very delicate personality, then I would give very oval tooth shapes. So in general, that's what is regarding in terms of your tooth shape. Now, in terms of smile analysis, of course, there are few things which are important. Number one is whenever we capture any record from a patient, which is, I think, very important. So, if you're not taking photos till now, I would highly recommend you to start taking some pictures. The pictures of extraoral should always be taken when the patient is sitting straight, not on the dental chair. So please don't take any photos on the dental chair for extraoral photos, especially when you are planning an aesthetic case. The patient's head is supposed to be straight. Patient should be smiling and laughing as much as possible. So that's also an art that you have to learn to make sure that the patient is comfortable when you are taking photos. Few other factors that are important when it comes to a smile designing case. Number one, of course, is the central dominance. So what is central dominance is basically how prominent your centrals should ideally be. How prominent they are going to be will be based on the proportions, which of course are a part of this presentation, and I will be discussing them a little later. The next thing would be your smile arc, okay, or basically your incisal projection. There are many projections like a convex projection, a straight projection, and a triangular projection. But in general, I like to follow the contour of the lower lip when the patient is smiling, and most of the time that works pretty well. You have the tooth shape, which we have already discussed on how do we decide what tooth shape would suit the patient. And then there are factors like incisal angulations. When it comes to incisal length, now this is a factor that determines all your aesthetic cases. Whether you are doing a single, not single veneer, whether you are doing two veneers or you are doing a full mouth rehabilitation, this is your starting step. If you are not able to find the correct position of your incisor, anything else that you do is not going to be correct. So the first thing always in a case that involves an aesthetic change is the incisal length. How do we determine the incisal length? There is a rule called 42.2 rule. The 4 is the incisal exposure at rest for females. Generally, it's around 2 to 3 for males. So it's slightly more for females. The first 2 is the amount of pink that you should be ideally seeing. Again, it depends on the lip. Some people will have more lip, I mean, gums show, some people will have no papilla show. But in general, an aesthetic smile should have around 2 millimeters of pink seen. And the last two is the distance between the vermilion border of your lower lip and the incisal, final incisal edge position. So if you remember this 42.2 rule, you will be able to decide where your incisor should ideally be, right? There is also something called as phonetics, which we generally don't pay a lot of attention to. You can ask the patient to say F and V. and the incisal edge should generally touch the vermilion border of your lower lip. How do we decide this? There's something called as the direct mockup technique. I'm more of an analog person. Not that I don't know how to do scanning or I have not used scanners, but it is just that I prefer doing a analog way so that I can show the patient on same day what I can achieve. I know in my head what I can achieve because with Photoshop I can do anything, but whether it will be clinically possible is sometimes challenging. So this is one of the techniques that I generally teach during my courses, which will also be a part of the online Veneer course on next week on Sunday. So this is one of the techniques that we generally learn. It really helps in motivating the patients, converting the patients, letting them know what they have lost over the past few years. And in general, it makes a huge difference to you being able to convert a patient for veneers. So that's regarding the importance of incisal edge, right? Now, when it comes to proportions of teeth, this is also super important. When you read the research, there are a lot of proportions that are given in research. As a dentist, I mean, I would not expect anybody to remember all of them. Let's narrow it down to two most commonly used proportions. The first one is the golden proportion, which says that if my central incisor is X, my lateral incisor width is going to be 62% of my width of my central incisor. Now it's the golden proportion, 0.618, rounding off to 0.62. But again, whenever we use golden proportion in teeth, you would realize that your centrals are looking a little bit more dominant than they should. The centrals look bigger, the laterals look smaller. So in general, I don't prefer using golden proportions when it comes to designing my smile. What I like to use is something called as red. This is called the recurrent aesthetic dental proportion, which is almost 70% instead of 60%. So if my golden proportion was telling me that if my central is 10 millimeters wide, my lateral will be 6. The red will tell me that if my central is 10, my lateral is going to be 7. But what we need to understand is that to make that 7, I will have to reduce even 1 from the central also. So the proportions will become a little better. They look more harmonious when we use red. That is one. Second, it's an average value. So the average value goes from 65 to 75%. It's not a rigid value like a golden proportion. So you have some leeway to play with the proportions. And I always like to work with averages. Nothing fixed can ideally be achieved in the normal practicing world. So that was the proportion between your central to the lateral, lateral to the canine. This is the proportion of an individual tooth. Okay. Dr. Murshid, yes, I think I'll have to go again. If they can, I don't know how to remove these annotations. So kindly avoid doing annotations so that we can avoid that challenge. So now proportions of an individual tooth ideally is 80%. That means if the length of my tooth is around 10 millimeters, the width of my tooth would be around 8 millimeters. That's an ideal world. 99.9% you will not be working with ideal scenarios. So again, we like averages as I've told you. 75 to 85 is a decent place to be in. If I go towards 70, I'm making the teeth more triangular. We understood what is the problem with triangular teeth. The main problem with triangular teeth is, sorry, the main problem with triangular teeth is development of black triangles. Whereas if we go towards 90, we are going towards more squarish teeth, which ends up in more squarish teeth, which are not again very aesthetically pleasing to the eyes. So as I've told you, we'll mostly be working with 75 to 85% proportions. Ideal length to width ratio of the central is 80%. Ideal width ratios between your central to the lateral to the canine is around 70%. 42.2 rule to decide on your incisal edge position. So these all together will be able to give you the right central incisor for your patient. And getting the right central incisor in terms of the bulk, in terms of the position, in terms of the proportions is the most important factor when it comes to doing any case that involves central incisors, right? So that was some other factors that were related. The next thing that is of super importance, let me just go back and come back so that this annotation can go. I will stop the share once quickly and I will share again. Okay, sorry for that. Yeah, so kindly avoid annotations and let's continue. Okay, so apart from those, of course, there are a lot of other factors like midlines. Then there is something called as buccal corridors, and there were so other factors that we will discuss when we are actually doing the course. But this is what is important, like for the basis of your smile designing. The main factor is your central incisor, number one. Second thing was what was the tooth shape, and the third thing is the importance of soft tissue. Now, soft tissue is something that I really, really pay attention to whenever I do a treatment planning. If my soft tissue is not healthy on day one, then my soft tissue will never be healthy even after you finish your treatment. The goal is that before you reach the stage of your impressions, your soft tissue should ideally be healthy. So if you have an overhanging restoration that is causing the tissue to be inflamed, or you have done provisionals that are really bad, it would not be a great idea. Looking at these two pictures, the left picture is on the day of bonding. Look at the health of the soft tissue. That's 1 month after bonding, the soft tissue remains absolutely healthy. These are the case of upper and lower veneers done. 20 veneers placed for this patient, but the soft tissue remains immaculate because it was paid attention to. So health is of prime importance when it comes to doing anything that is prosthodontically related, whether you are doing an overlay, whether you are doing an onlay, whether you are doing a crown, you're doing a class 5 restoration, you are doing a veneer crown full mouth. If the soft tissue is not healthy, your result is not going to be a very long lasting results. In terms of aesthetically, generally the zenith point of the central is same as of the canine, lateral is slightly below that. Again, it becomes of great importance when the lip is a little high. So the case that I posted on Instagram a couple of days ago, I can see my two centrals are at a slightly different level. Okay, but again, I would not want to achieve perfection. Patient was happy with it. Patient was well informed that this might be a possible scenario. I didn't want to do gingival surgery on the implants. We have a little bit of disharmony. Patient is fine with it. I would not really pay attention to make it absolutely perfect. A little bit of imperfection always gives the character to the person. Imperfection doesn't mean bad work. Imperfection means that it is either not symmetrical or there is something here and there, but that doesn't mean you don't do your job properly. Second thing which I discussed was the health. If your periodontal health is good, your restorations are going to last longer. Similarly, if your restorations are good, your periodontal health would be maintained for a good amount of time. So just summarizing a part of my lecture, any patient that comes for any kind of treatment to you, the first thing, of course, is attention to detail. So you pay attention to detail from how the patient walks into the clinic. Are they arguing with the reception? Are they thinking about the money? Are they not, interested and motivated enough? Then no point of talking and doing direct mock-up on those patients because you know that they will never be convinced, or they might feel that you are a salesperson and you are trying to sell them a treatment which you really are not intending to do. Second thing is establishing an accurate diagnosis, right from an individual tooth to the airway to the overall diagnosis. Everything is important, whether the patient is a bruxist, whether the patient has got erosion. Taking the proper history is super important. Please make sure that from today onwards, always ask the history of stress and reflux to all the patients. It's increasing quite a bit these days. A lot of erosion cases I see, which are partly responsible because of reflux, partly responsible because of the acidic drinks that people are drinking. The third thing, of course, is the comprehensive treatment plan. So you need to make a proper treatment plan for the patient. You have to make sure that the plan is accurate and you stick to it. And finally, you should have the knowledge of new materials and techniques, which will also be a part of the course. As we discussed, we'll discuss all about ceramics. We will be discussing about um, impression materials. We'll be discussing about bonding. So there is a lot to be learned during those 2 days. And of course, if those 2 days seem less, and if I feel that I am kind of rushing, I will add a third day to the course as well. All right. So that was regarding your patient's smile designing, importance of soft tissue, and what all you need to basically be able to do a case. Moving on to the next part of the lecture, which is about consent. Now, this is something that is generally not taught to us very well when we are in the university level. I really want you to understand that it's an irreversible modality of treatment. So first thing is, if you feel that there is an alternative, please do that. Okay. Don't crowding is not an indication to correct your, sorry, crowding is not an indication to do veneers, right? So if you feel there is crowding, first try to do Invisalign or orthodontic treatment, get the teeth a little better aligned, discuss with the orthodontist, plan the treatment together, and in the end do the veneers. Because again, the more you cut the tooth, the more you are taking the tooth closer to the end life. A good veneer would last roughly 10 to 15 years. That is, if you have done it extremely well and the patient maintains it well. You don't want to cut teeth for very young people. You don't want to do veneers for 18, 19 years old in most of the scenarios unless clinically indicated. So the consent should include the benefits that you are doing. The consent should include the alternatives, and it should also include the risks, which I have already told you. Number one, the life of the veneer. Number two, it's a preparation technique, irreversible, aggressive, possibility of sensitivity, and so on and so forth. All right. Once you have decided and you have done your direct mockup, you will take some record from that direct mockup and you are going to tell the technician to do your wax up, which is shown on the left side, or you will ask the technician to do your 3D printing smile design. It again depends on whatever you feel like doing it, but it will be based on your calculations. The technician is not doing a smile design arbitrarily. I am telling the technician to, uh, one second. Everybody, can you please just mute yourself? Sorry for that. Let me do that. 1 minute, please. Sorry. Done, I think. All right. So you have to tell the technician the shape of the tooth. You need to tell the incisal edge position. You need to tell the width of the central. You need to tell the bulk of the central. You need to tell the shape of the tooth. Everything is guided by you and not the other way around, right? You are the boss. The technician is not the boss of your smile designing case. Okay. They can help you. They are of an absolute importance to finish the case, but the treatment is decided by you as a dentist. Okay. We are going through all of these during the course. So we will have a live demo of a full coverage index, a clear index, an incisal index, and the guide index. All my preparations are generally done guided. They are never arbitrarily done. We will learn how to make a full coverage index, which is the index that you are going to use to make your provisionals. You are going to do your indirect mockups, and you are also going to use for your guided preparations. So this is a super important index that we learn to make it the correct way. The picture shown is not the correct way. This is a lab fabricated index. I generally fabricate my own indexes. I don't use condensation polyvinyl siloxanes. I use addition polyvinyl siloxanes to make my indexes with a light body. So we will learn the full coverage index. We will also learn how to make the guide indexes, because these are the indexes which are going to help you to prepare your teeth adequately without over preparing them. So this is also a super important index. Once, if you want to do like proper veneer preps, if you want to see how your preps look, then this index would really help you in achieving that kind of a preparation. My armamentarium wise, I am very selective. I have my own burst set. It's a very small, tiny burst set. I can do veneer preps with just 2 or 3 bursts maximum. I don't have like a lot of bursts. I can teach you full prosto in one burr. That's all. If you have the first burr that is shown there, which is the 198018, it is 1.8 millimeters wide at the widest portion and around 1.6 or 1.5 at the tip. It's a round-ended tapered diamond point, and it's my favorite burr to be used for your preps. Then you have the guide burr, which will help you getting the initial depth grooves. Of course, I will not be able to take you through the full preparation today, but that's again a huge part of the course. The thing that is important here is to understand what kind of preparations would you ideally do. So there are basically 4 kinds of preparations that have been given in research. I mean, in terms of the veneer prep, the type A, which is your, sorry, the type A, which is your window prep. I would hardly ever do it if I'm doing veneers because most of the times when I'm doing veneers, I am changing the position of my incisal edge. So type A is just a window prep of no use. Hardly I would ever need to do that. Type B is the feather edge, wherein you have a feather edge on the incisal edge. The risk of a type B preparation is your tooth is also very thin, your ceramic is also very thin, very high chances of fracture. Again, not the preparation type that I would do. Type C is what I do in 100% of my cases, which is an incisal bud joint. By doing an incisal bud joint, you have a good enamel to bond to, you have good thickness of tooth, you have got good thickness of ceramic, and overall you are in a much better position whenever you are doing a butt joint preparation. And type D, which is your palatal overlap, I think it's again not of any use to me. I would always do a butt joint preparation without a question. Okay, there are reasons for not doing a palatal overlap, but the main reason for not doing a palatal overlap is if you are doing a milled veneer, then the burr that actually mills the ceramic is thicker than your incisal edge, and you will always have a veneer that doesn't really adapt very well to the prepared tooth. So how much we have to prepare will depend on number one, how much bulk are we adding to the final veneer. But in general, the incisal thirds enamel is around 1.8 millimeters thick. In middle, it's around 1 millimeter or zero point 0.8, and in cervical, it is the thinnest. So generally, we tend to keep our reduction zero point 0.5 on the tooth. That's the maximum that I would do overall. Yes, I would do a little bit more based on my initial position of the tooth. So if all the teeth are being prepped, one tooth is slightly proclined, that tooth would be prepared a little bit more. There is no doubt about that. All right. So that's my preparation protocol. That's what we will be focusing on during the course as well. We do the indirect mock-up, we do the horizontal grooves, we do the vertical grooves, we remove the mock-up, and that's what we get. Those are the final veneer preps, all of them with bud joint, all of them 100% in enamel. So you get very nice achievable results. We will discuss in detail uh, where to place the margins, when to place the margins subgingival, when to break the contact, when to not break the contact. But again, that is out of the scope of today's lecture. But what I want you to understand is that it's always better to do a guided preparation, do a minimal preparation, have the preparation in enamel, use a proper cord while doing your retraction. I generally do impressions. Again, if you want to scan, please go ahead and do it. I find my veneers fitting better when I make an impression. That's on the day of bonding. So you see that soft tissue is healthy. The veneers are well wrapped within the tooth. You will not be able to see any tooth, and you will have a very nice result, less bulky veneers and much more natural looking veneers. Your impression technique is something that is again super important in terms of retraction. So once your veneer preparation is done, I like to always do a cord retraction. That's my armamentarium of the cord packing. I have viscostat clear, which is an aluminum chloride based hemostat. I generally put a single cord of 00 if it's a veneer prep because most of my preps are either equigingival or slightly supragingival when I do veneers. Only in very selective cases I go subgingival. So if I'm going subgingival, I will do a double cord in that particular area. Otherwise, it's mostly one single cord, and that would be enough for me to be able to achieve a proper retraction and a fantastic impression. So as we discussed, I do more of impressions now. I have done all kinds of scanning. I've used iTero, I've used 3Shape, I've used Prime Scan, I've used every other scanner as well. But even my lab tells me that, doctor, if you are scanning, please also do make an impression. So I feel like with impressions done properly, you will be getting good results. Don't just start scanning if you don't know how to make a good impression, because if you don't know how to make a good impression, it is very challenging that you will be knowing what mistakes you have to look for when you are actually scanning. So be careful. All right, once your impressions are done, you have got your temporaries on, you are sending it for your fabrication of veneers. Now, in the ideal scenario of classification of ceramics, we should be able to classify ceramics based on where to use the material, what type of restorations, and how do we loot it, right? So again, it's a full topic of discussion. What we need to understand that for veneers, generally there are choice of two materials. One, it's your feldspathic ceramics, which is a naturally sourced glass-based ceramic. The strength of feldspathic is weak, especially when it is not bonded. It's very aesthetic, but we compromise on strength. The other option that I would choose always is lithium disilicates, which are generally either pressed or milled. It will be based on the lab. And of course, if I want slightly more strength, I am going to tell the lab to do a pressed veneer. All right. So we do a lithium disilicate. Most of the times I will do a lithium disilicate, but because both of them are glass ceramics, the bonding protocol would remain the same. This is an overlay, but in general, for any lithium disilicate, the bonding protocol would remain the same. If you follow this bonding protocol for lithium disilicates, there is a very, 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 very little chance that you will have D bonds in your veneers or your any restoration that you do of lithium disilicates. The main thing is to remember that we need to preserve enamel. If you don't have enamel, the bond is not going to be strong, number one. Even if it is strong, it is a bond that deteriorates rapidly. So why we want enamel is not because the bond is stronger. We want the enamel because the bond is more stable. It's a very highly inorganic material, enamel. You can bond it properly. The bond is stable. There is no hydrolytic degradation of bond in enamel. And that's the reason why we want a lot of enamel whenever we are working with bonding glass ceramics to tooth. So the steps are, of course, we will put the hydrofluoric acid, which is generally available in 5% or 9% for 20 seconds. Recommendation wise for lithium disilicates, it's 5%. For feldspathic, it is 9%. But again, if you don't have a 5% and you are doing a lithium disilicate, use the 9%, but use it for 15 seconds. I have never had a problem with using a 9% on lithium disilicate. Always look for a glaze. What happens is in veneers, this generally doesn't happen much, but still you have to look for it. Sometimes when the lab is doing a glaze for your lithium disilicate, a drop of the glaze would come on your bonding surface. If that glaze is not removed, there is no bonding happening in that area. So you're going to take a football burr at a very slow speed, very gently. Don't break your veneer. You're going to remove that glaze. You're going to re-etch with hydrofluoric acid. Then you are going to put the hydrophosphoric acid to clean the tooth of the debris that was left from hydrofluoric acid, right? Your overall veneer should look absolutely frosted. It should look nice. Don't overdo the etching. You don't have to sandblast your lithium disilicates. Sandblasting lithium disilicates make them weak. A lot of cracks are introduced, and it's not a great idea to sandblast your lithium disilicates. So you're only going to etch them with hydrofluoric acid. Now, the next step is controversial a little bit again. It's not and, first of all, it should be silane or the bonding agent. Why I have written both? Ideal recommendation is to apply a layer of silane on your lithium disilicate. What does silane do? Silane acts like a mediator to help bond your ceramic to your resin cements, right? So some companies would recommend applying a silane separately. Now 3M as a bonding agent, which is your universal bonding agent, has got silane already in it. Some studies would say that the silane in the universal bonding agent would get deactivated because of the acidic nature of your bonding agent. I have been using it for 13 years. I have never had a debond of a veneer. So it works pretty fine. So you can either apply a universal bonding agent with silane in it, or if you want to be on the safer side, just apply silane on your lithium disilicate. For the tooth, so your ceramic is now ready to bond. For the tooth, we generally do selective etching. So we are only going to etch enamel. We will not etch dentine. We are going to use a bonding agent that contains MDP. So I'm telling you these because these are important. If your bonding agent doesn't have MDP, you are not doing proper adhesive dentistry in the current world. You need to have a phosphate monomer in your bonding agent. So your clear fill SC, your self-adhesive resin cements, I mean those are cements, but and your universal cements would have MDP. So, or if a bonding agent is called a universal bonding agent, that means it has got MDP or a very similar phosphate monomer in it. So you can use either Clearfill SC, you can use OptiBond FL, you can use even your universal bonding agent from 3M. So you're going to selectively etch the tooth. You're going to scrub the bonding agent on the tooth for roughly around 10 to 15 seconds. You're going to dry the bonding agent for around 10 to 15 seconds. And then for veneers, generally I prefer using a pure light cure resin cement. I don't use a dual cure resin cement for my veneer cases unless my veneer is thicker than 1.2 millimeters, which it can happen in some cases, or if I've applied an opaque layer in my lithium disilicate veneer because my tooth was really dark in color. In those cases, I might use a self-adhesive resin cement, but most of the time with lithium disilicates or glass ceramics or feldspathic, I would use a pure light cure resin cement, which would be like the Rely X veneer cement or the Multilink, I think also is a pure light cure resin cement. My adhesives have always been from 3M since the time I started my dentistry, and they are working good. I don't want to change them. They are working fine, and I'm quite happy with how they work in the mouth. So to summarize today's lecture, all right, some things are very, very, very important for you to understand. Number one, incisal edge is an absolutely important parameter when it comes to smile designing. Tooth shape is what you will kind of understand when you do more cases. More rectangular for more aggressive people, more rounded for more delicate people, and that's how it goes. We generally use the red proportion when it comes to the proportion between central to the lateral to the canine, which is around 70%. We use the 42.2 rule, which is your 4 millimeters of incisal display at rest for females, 2 millimeters gingival display, and 2 millimeters distance between the vermilion border of the lip and your final incisal edge position. Direct mockup is a technique which I think everybody should know. It's a fantastic technique to show to the patient, for you also to understand how the case is going to proceed, and it will really help you in converting your patients to be more happy to get the treatment done. Soft tissue, prime importance. I think the health of soft tissue is a very neglected topic. Please pay attention to soft tissue before you start a case. It is of extreme, extreme, extreme importance. That's the second thing. The third thing is what I have discussed today is about your preparation, armamentarium, the magnification, and the consent. We only do the butt joint preparation. I don't do other kinds of preparation. Even the research wise, the butt joint is the most successful preparation when it comes to success of veneers. Ideal provisionalization, proper contouring of the provisional. There should not be any excess. The soft tissue should remain healthy on the day of bonding. The choice of material would be either feldspathic or lithium disilicate. Zirconia veneers generally are not recommended. They cannot be bonded as well to the tooth as your glass ceramics. The bonding will be your hydrofluoric acid on the veneer, hydrophosphoric acid on the tooth selective wedge. You need to have the silane on the veneer. You need to have the bonding agent with MDP on the tooth. You need to have a light cure resin cement to attach both of them. So you have a proper bonded veneer or a glass ceramic or a lithium disilicate, which would generally not come out. And finally, we do adjust the occlusion so that we make sure that we don't end up with having our results fail. And the last thing is to have a properly motivated patient, which is of extreme importance. So if you feel that your patient is not motivated enough and you are trying over hard to convince the patient, don't do the case, because if it fails, patient will never accept their mistake. It's always going to be you who has done the treatment, you who doesn't know how to do the work. So choose your patients wisely. Not every patient is a candidate for veneers. It is an aggressive treatment modality and it is not an easy procedure. So don't feel like if you see those Instagram pages where there are thousands before afters, it doesn't work like that. You don't know how their preps were, you don't know their follow up, you don't have their x-rays, you don't have it. Anybody can do a nice white ceramic and stick it onto the tooth and it will look nice. The idea is to have a successful result that would last for roughly around 10 to 15 years. So that's what we really want from our lecture. Okay, sorry, from our treatment, right? So I will be stopping the screen share right now. We are going to have a nice question answer session. If you have any questions regarding veneers, anything that we have, I have another 30-35 minutes. We can have a proper discussion. Before I stop the screen share, once again, I would like to show you this in case you have not aware about it. That's the Veneer course that is going to happen on the 29th and the 6th of July. 29th of June and 6th of July. It's a 2-day masterclass on veneers. I will be covering each topic. There are amazing videos that would be shown to you. Each step has got a proper video fabricated. So we will have a proper discussion. So you have HD videos of these qualities that we will be having a discussion on, right? So it will be a really nice course, I think. Sorry, it's not moving. So it's all about learning how to do the preparations properly, how to, kind of understand, do the provisionals, do the bonding, do the isolations, and so on and so forth. So please do, I mean, if you have not registered and if you really want to attend it, drop me a text, and then we can help you with the registration bit of it. There will be a recording of that course that would be provided for 3 weeks and a certificate as well that I will make it sometime in the future and we will give it to you as well. All right. So once again, I would like to thank you for attending today's lecture. I will be uploading it on YouTube for a 2-week period. You can see it if you want to see it again, make some points if you want to, and I will be more than happy to help you out with any questions. All right. So couple of questions. 42.2 rule, I will repeat it again for whoever has asked. So 4 is the incisal display at rest for females, around 2 to 3 for males. 2 millimeters of the pink visibility when the patient smiles. Again, not all the cases can be 2. Some will be more, some will be less. But for a smile to look good, you should be able to see some of the pink. And the last 2 is when the patient smiles, there should be a gap of around 2 millimeters between the 1 million border of your lower lip and your incisal edge. Can you explain the steps from mock-up to wax-up? What are the requirements from our side? So basically, when we do a mock-up, there are a few things to remember. We need to measure the length, what looks good on the patient's mouth. You need to measure the width of your central incisor, what looks good and what you have decided. You can send one of the wax composites to the technician to check the bulk. You can also take a photo. You can take a scan of the mock-up that you have done. You can make an impression of the mock-up that you have done. So the technician will have all the variables that the technician needs to do wax up based on your direct mock-up. and not just an arbitrarily done wax up. For premolars also, so for premolars, it's generally three kinds of preparations that I generally do for veneers. One would be a minimal prep that would involve just like preparing a canine. So you have around 1.5 millimeters of buccal cusp that is covered by ceramic. The second would be slightly more aggressive, where we go up to the midline. Again, based on the contact, old restorations, cavity, so on and so forth. And the third prep would be like an overlay plus a veneer lay preparation. So you have the full veneer and the full occlusal covered with your ceramic. And that preparation is also discussed in the course. So we have all the three preparations for the premolar, but it is always a butt joint. There is never a bevel. There is never any kind of an overlap. Phonetics, mainly what you need to understand is F and V sounds. Okay. So the F and V sounds are super important. When the patient says F and V, the incisal edge should be touching the vermilion border of your lower lip. So whenever you are doing your wax ups or mock ups for the patient, you should ask the patient to say F and V, and that's when you check the what do you call the incisal edge position. So for phosphoric acid, generally I do use it after the hydrofluoric acid. It doesn't really do much, but whenever you etch a glass ceramic with hydrofluoric acid, it leaves some residues. So to remove those residues, you need to just put phosphoric acid on the veneer to just remove those residues. How to clean on adjacent teeth while bonding veneers. So generally how I bond my veneers is two at a time. I always would do central incisors, both of them together. I'll put a Teflon tape on the other if I want to, or you will always do. I generally don't do sandblasting that often. So I will take some pumice and a brush and just clean the teeth before I actually bond to the tooth. That's easy, fast, economical, and it works pretty well. For only same protocol, the veneer, the lithium it's a bonding protocol for lithium disilicate, not the bonding protocol for veneer. So any restoration that is made of lithium disilicate or feldspathic would be bonded in a very similar way. My voice got muted. Am I muted? You can hear me,
No,
right?
doc, just in between. In
Okay.
pieces, yeah, we can hear you, but in
Okay.
pieces, it just vanishes.
Okay. Sorry for that. Yeah.
No problem.
We can do veneers only for lower 3-1. You can do for veneers for anything. I generally, my veneers are either 1, 2, 4, or 10. I don't do 6 and 8, especially for the uppers, because when we do 6 and 8, there is a sudden lateral buccal corridor that gets more accentuated if I do only 6 or 8. But yes, in case of diastema, you can do two veneers, absolutely works. But again, it depends how big the diastema is. If the diastema is really big, then I would involve either an orthodontist to distribute the space, or I would do four to have better proportions, because you do not like two bulky, broad central incisors next to two thin lateral incisors. So that would be the thing. It is very difficult. What I would always do if the tooth is discolored and root canal treated in my clinical practice, I always do an endo bleach. So we whiten the stump of the tooth always, so that I don't have to really worry about the darkness. That is one. And the patient always goes to the technician after the veneer is generally fabricated. The technician would hold it in the mouth and shade it then and there. The patient comes back to me and I actually bond it. So one veneer is tough. It will never be 100% match because the texture of the tooth is different. The veneer is new. The tooth has been in the mouth for so long, so on and so forth. We try to just match as close as possible. Provisional, generally I do the same way I do my indirect mock-up. So it's done by like pro temp or a turbo temp material, which is like your what do you call the temporary crown and bridge material, and that's what I do for my provisionals. This is a question, Dr. Advait, that is again, I would not say controversial, but it's your choice. If you want to do it, do it. I don't do it because I don't bond 10 veneers at a time. I either bond two or one at a time. Takes more time, but I have the full view for me to check the fit of the veneer, it's nicer to have it without the rubber dam. I can clean it, polish it, take an IOPA or a bite wing to check excess cement, so that's also not difficult. Me and my assistant can keep a tooth dry for 45 seconds, and that's what I generally need after I have prepared my tooth. So I prepare my veneer, keep it ready, etch the tooth, bond the tooth, one tooth, two teeth at a time maximum, and I'm sure that I'm bonding to a quite good isolated tooth. It becomes a challenge more in the lower teeth, but upper teeth, I think it's fairly okay. Like I've never had a problem bonding without a rubber dam. Any change in protocol if the margins have composite restoration? So you can, if the person has composite restorations, you can use a sandblaster to roughen the composite. I would rather just change the composite and do a new composite before making the impression, or I would remove the composite and make it a part of my veneer. So, I mean, that's the old composite that I don't know how it was done, when it was done. I would generally remove it and change it to a newer one. I would want my margins to mostly always be on sound tooth. That way, I know that I'm going to have a reliable bonding. So that's, I think, anybody else, any questions? Anybody wants to unmute themselves and ask anything? Still have time if you want to. If not, then we are done. I've made sure that I've answered all the questions. Yeah. All right, guys. I think everybody is in a good zone. Thank you again.
So,
Sorry, one question came. Okay, tell me, please.
so can you please tell about temporization?
So temporization is again done by the full coverage index. I don't do etching. I don't do bonding. It's a single unit. The material really shrinks a lot, and you would not have what do you call a problem of the temporary falling out. So I will not do. I don't do any spot etching or bonding. I mean, if that is your question.
Fine.
Hi,
Yeah.
hi, doctor. Doctor, can you tell, how do your appointments go? Like, for example, some patients want them really fast. So, how do you plan your appointments? Like, what steps do you have?
So I will tell you one good thing here, okay? This is for your peace of mind, okay? The more you work, you will realize that the peace of mind is the most important thing that we should strive for, okay? So first, if the patient is saying, I want it quickly, not happening, okay? Because you never know. We don't commit anything that we cannot do always, right? Okay, in some patients, I would say I will do it in 1 week, okay? I will do the prep, smile design, everything. I'll push my lab and do it. But what if the veneers come and they're not fitting, they're not matching? Then you are in a tough situation. So always prepare the patient for a time frame. Roughly 2 weeks is what I tell them. Minimum that would it take. If it comes early, that's what I do. So my first appointment is direct mockup. Patient gets convinced. I take money for indirect mockup. Then goes to the lab. In 1 day or 2 days, my lab will send me the indirect mockup in like the wax up kind of a thing. I'll make my own index, call the patient. We do our indirect mockup, show it to the patient. If the patient likes it, I can prepare it the same day through the mockup if I have time. If I don't have time, I'll book the patient next day, repeat the indirect mockup, prepare the teeth, do the impression or the scan, provisional, and in 5 days, my lab will be able to give me 10 veneers. So 2 weeks, I'm done. That's generally the protocol that I follow. KY
Thank
jelly.
you so much, doctor.
Yep, I hope I answered your question. All right. KY jelly after bonding, yes, that's a good point. So you always final cure under KY jelly because you want to cure the outermost layer of the cement, which is again a resin, which we know will not cure because of oxygen inhibition. So you can put some glycerine or KY jelly and cure it under it. So that's a great question. Thank you. When we will get the recording, I will try to do it today itself, but max by tomorrow you will get it. How you will get it is I'm think it will be uploaded on my YouTube. Okay, so I will be sharing my YouTube on. You can search my name on YouTube. You will find my channel. It's called the Smile Rehabilitator. Okay, And I will anyways put a story on my Instagram as well regarding the video being shared on my YouTube. I will share the link on all my WhatsApp groups as well. So mostly you will somewhere see it. Okay. And if by chance you are not able to find it, drop me a text on WhatsApp or Instagram and I'll share the link with you. So don't worry about it. Dr. Vikram, generally there is no recession during retraction if done properly, unless you are like literally pushing and breaking the junctional epitheliums. One single cord done properly would not cause much of a recession. So that's something that I have hardly seen that a properly placed tossed cord would cause any kind of a recession. And even if a tiny bit of recession is caused, it would generally grow back. Veneer prep in case of spacing, again, I cannot really discuss all this today, but in case of spacing, what you need to understand is only one important thing, that in case you are closing a diastema, your margin has to be placed subgingival in that particular area. So if you're planning to close diastemas, the margins have to go subgingival. Only then you will be able to properly close the spaces. Otherwise, you will still end up with a black triangle or a bulky looking veneer. So in case of spacing, the only thing you need to remember is to go subgingival. How to avoid recession? Like recession won't happen if you have done your prep properly. If you have done your prep properly, if you have done your retraction properly, why would you have recession? Only if you have an improper restoration, you have a poor emergence profile of your final restoration, you have left excess cement, you have traumatized the tissue a lot, only then you are going to get recession. Otherwise, why would you get a recession? There is no reason for having a recession. Floss tie technique useful during veneers. If you're talking about rubber dam isolation, yes, why not? You can use a floss tie. Again, it depends on where your margin is placed. If your margin is deep, then you will have to use the Brinker clamps to push the dam below the margin. I am more of a fan of a cord. I don't like astringent paste, but if you think it works good in your hand, go for it. But as a prosthodontist, I have always used a cord, and I feel that gives me the best kind of a retraction. Enamel hypoplasia, again, you can do it. There is no contraindication, but the patient should be aware that the enamel is weak. The bond is going to be weak. The success cannot be expected to be absolutely fantastic. If it's a very, very, very heavily defected enamel hypoplasia, then a crown would be a better option. After a direct mockup is, yes, it is always needed because direct mockup is done in 2 minutes. So you need to have a proper indirect mockup that is going to provide you a baseline for your final veneers. That's the baseline through which you do your preps. So none of the steps that I've told you is a skippable step. All the steps have to be done. I don't use on gluma. I don't want to affect my bonding in any way. If you do your bonding protocol properly, there are going to be cases that will end up with sensitivity. Nobody in the world will be able to say that none of their cases are without sensitivity. Whoever they are in the world, whatever they do, it all depends on the patient's adaptability also sometimes. So you can minimize it if you do a proper bonding with MDP and follow the correct technique. Chances of sensitivity are less. So I don't see a place for gluma for veneer preps. I've told you how I do is again same like how I might do my indirect mockup. I will place the same material in the same index, put it again in the mouth, let it set. That's it. It is a super easy protocol for doing a provisional. Single step, no etch, no bond, no cementation, nothing. Especially if you're doing 10. If I'm doing 1 or 2 veneers, then I might use a temporary cement or just flow in some light cure, flowable composite and hold my temporary for 3-4 days. Yes, I mean, I generally cure my light cure bonding agent along with my cement. That's what's the company's recommendation. So we always follow the manufacturer's instructions and we kind of work with a similar scenario. So whatever the manufacturer is saying, you are going to do exactly the same thing. Okay, so I mean, I generally cure everything together. Anybody else? Any questions? Same thing. I'm telling you, it doesn't really matter whether it is enamel plasia, fluorosis. If the enamel is weak, the bond is weak. You need to tell the patient that the bond is going to be weak. That's all. If you feel the fluorosis is so much, then you do a crown. Okay, so be on the safer side. If you feel the fluorosis is large, the tooth is completely mottled, do a crown. If the patient is very young, heavy fluorosis, you want to preserve, you want to be conservative, do a veneer, tell the patient that it might fail. If it fails, then we still have an option of doing a crown. So it's all about communication. It's all about the patient understanding your plan, but that's what it is. You can use, I use dual cure cements. Mainly, I use a self-adhesive resin cement for all my overlays that I do. All of them are lithium disilicates, and for all of them, I'm using a dual cure resin cement. So there is no restriction for that. But for veneers, I generally use a light cure resin cement because sometimes they are very thin. The dual cure can sometimes stain, and I would not want the stain to show through my thin veneer. So that's pretty much it. Awesome. Guys, thank you so much for coming in. If anybody would want to join the course, you are more than welcome. We have good 100 people who have registered for the course. So anybody who still wants to join in, we have 1.5 weeks. You are more than welcome to drop me a text and I'll help you with the registration. I hope you had a good time today. Thank you so much. And I will be sharing the video soon.